1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Picture a broken arm on an x-ray. It's, binary, clean, just a jagged white line. You point at it, you splint it, you move on.
Right, yeah, very straightforward.
Exactly. But the second you step into the world of respiratory critical care, airway management, and mechanical ventilation, that x-ray machine just shatters.
Oh, absolutely.
You're suddenly navigating this diagnostic landscape that is entirely murky. You aren't just looking at structural damage, you're watching physiology fail in real time.
I mean, it is the absolute definition of muddy waters. You are balancing invisible pressures, blood gases, and hemodynamics that are shifting, like second by second.
Yeah.
And that requires a complete cognitive shift. So today, we are aggressively applying the Pareto principle to this.
The 80-20 rule, right?
Exactly. The intensivist mindset. We're ignoring the fluff. We're isolating the core pathophysiology that will actually save your patient's life.
Which is what this is all about.
Right. It dictates your bedside decision-making and helps you anticipate the exact moment a patient's going to crash.
And to make sure this stays brutally grounded in reality for you, our listener, sitting there ready to elevate your practice, we are chaining this entire deep dive to one specific patient from our source material. I want you to really visualize him.
Yeah, RK.
Right. RK is a 72-year-old male who collapsed at home. When the paramedics found him, his respiratory rate was 32 breaths a minute.
Which is exhausting.
Oh, totally.
Right.
And by the time he crashes through the ED doors, his blood pressure has completely tanked to 84/49.
And look at his oxygenation, too. His SpO2 is sitting at 84%.
Wow.
And that is despite the paramedics maxing him out on high-flow oxygen.
So he's in deep trouble.
Extremely. Neuro-wise, he has weak, non-purposeful movement. When you put your stethoscope to his chest, you hear these coarse bilateral crackles, and you can physically see he is struggling against thick, purulent secretions.
This is the pre-intubation battlefield.
Yeah, the man is actively dying in front of us.
Yeah.
Everything we discussed today is about saving RK.
So we're going to follow him from this moment in the ED, right through the trauma of intubation, manage the hemodynamic fallout, and eventually try to liberate him from the machines. Let's start right at the bedside.
Okay.
The immediate problem is airway clearance and profound hypoxemia. The absolute 80-20 rule here is that if you don't have an optimal route for ventilation, all the oxygen therapy in the world is completely useless.
Exactly. I mean, let's look at the cellular and organ level pathophysiology here. The trigger is a physical obstruction.
So in RK's case, those thick secretions.
Right, and likely some bronchial collapse, given his age and COPD history. That physiologic change leads directly to a massive disruption in gas exchange.
Because the alveoli are just blocked.
Yeah, so oxygen cannot diffuse across the alveolar capillary membrane into the bloodstream, and carbon dioxide cannot diffuse out.
So what's his body doing about it?
His compensation mechanism is that respiratory rate of 32. He's desperately trying to pull in more volume to overcome the block.
But he is actively decompensating, right? That's why we see the weak, non-purposeful movement. His brain is literally starving for oxygen.
Yes.
Now, the overwhelming instinct here, especially for newer nurses when you see SpO2 of 84%, is to just crank the oxygen flow to the absolute maximum.
Which is a huge mistake.
Right. We tend to think of oxygen as this harmless, magical gas. But looking at our notes, if we just blast RK with 100% oxygen, we could trigger something called absorption atelectasis. I really want to break this down because the physics here are fascinating.
It's crucial.
Think of nitrogen gas as the structural tent poles of your alveoli.
That is the perfect mental model for this. To understand why blasting oxygen is dangerous, you kind of have to understand the air we breathe. Room air is about 78% nitrogen and, 21% oxygen.
Okay.
When that air travels down into the alveoli, the oxygen quickly diffuses across the membrane into the blood. But the nitrogen does not.
It just hangs out.
Right. Nitrogen doesn't cross the alveolar capillary membrane easily. It stays behind in the alveolus. And because it stays behind, it exerts a physical pressure that maintains the size, shape, and structure of the alveolar sac.
So it literally holds the tent open.
Exactly. So what happens when a patient like RK has a partial obstruction and we just slap a non-rebreather on him at 15 liters, giving him nearly 100% oxygen?
You're actively washing out that ambient nitrogen.
Yes, you're replacing the nitrogen in his lungs with pure oxygen.
And because he has an obstruction, meaning fresh air isn't circulating well, that pure oxygen just sits in the alveolus and is rapidly absorbed into the blood.
Right. But now, there is no nitrogen left behind to hold the space open. You've knocked down the tent poles.
Wow, so the alveolus completely collapses on itself.
That is absorption atelectasis. By trying to fix his hypoxemia with too much oxygen, you physically destroyed the surface area he needs for gas exchange. You've made his hypoxemia exponentially worse.
That completely flips the script on how we view oxygen therapy. And it brings up another massive respiratory myth we need to crush right now. I hear this on the floor all the time, the hypoxic drive in COPD.
Oh, this one.
Yeah. The fear is that if you give a COPD patient too much oxygen, you'll knock out their drive to breathe because their chemoreceptors have lost sensitivity to high CO2. We call it CO2 narcosis.
This is a classic exam trap and honestly a really dangerous clinical misconception.
How so?
Well, the idea is that healthy people breathe because central chemoreceptors detect rising CO2 levels. Over years, a severe COPD patient who chronically retains CO2 might experience a blunting of those receptors.
Right, so their primary stimulus to breathe becomes hypoxemia, low oxygen detected by peripheral chemoreceptors.
But the hypoxic drive is incredibly complex, and not all COPD patients are chronic retainers.
Right, and even if they are, the intensivist rule is crystal clear here, right? You never, ever withhold oxygen from a patient in acute, life-threatening distress.
Never. The danger of withholding oxygen and letting them die of acute tissue hypoxia far outweighs the theoretical risk of reducing their respiratory drive.
Because if they stop breathing,
You just support their breathing with positive pressure. But if you let their brain and heart cells die from hypoxia, you cannot reverse that. You treat the immediate threat to life first.
So as we assess RK and patients like him, how do we spot early failure? How do we catch this before their blood pressure tanks to 84/49?
Early on, your focused assessment must center on the work of breathing. Look for accessory muscle use.
Like the sternocleidomastoid muscles pulling.
Exactly, or supraclavicular retractions. Look for subtle dyspnea and, crucially, mental status changes. RK's weak, non-purposeful movement is a massive red flag.
Because the brain uses 20% of the body's oxygen, right?
Right. Before the skin turns blue, the brain gets confused, agitated, or lethargic.
And the late classic, highly dangerous findings.
Central cyanosis around the lips and mucous membranes. Or a dropping SpO2 that refuses to climb despite escalating high-flow oxygen.
Which means
That means you have a severe physiological shunt. Blood is bypassing the lungs without picking up oxygen. That should immediately terrify the nurse because respiratory arrest is imminent.
let's talk diagnostics and targeted goals. We're pulling arterial blood gases, or ABGs. For our PO2, the partial pressure of oxygen dissolved in the blood plasma, we want to target greater than 60 millimeters of mercury.
Right.
And for our SpO2, which measures the hemoglobin saturation, the general target is greater than 92%. Though, for our chronic COPD patients, a target of 88 to 92% is often acceptable to avoid the atelectasis we just talked about.
To frame this clinically, we have to constantly assess, diagnose, plan, implement, and evaluate. Your ADP-ID.
Okay, let's break that down.
Your priority assessment is recognizing the failing airway. The nursing diagnosis here is ineffective airway clearance paired with impaired gas exchange.
And the plan?
Your measurable planning goal is maintaining that SpO2 greater than 92% using the lowest possible fraction of inspired oxygen, or FiO2.
And for implementation, we aren't just adjusting dials on the wall. We are using independent nursing actions, right?
Yeah.
Breathing exercises, airway clearance techniques, optimal positioning.
Exactly. And your evaluation is successful if you see normalizing ABGs, a decreasing respiratory rate from that scary 32, and improved mentation.
Let's structure our priority nursing actions for RK right now in the ED.
Okay, first, you optimize mechanics. Sit the patient straight up to maximize diaphragmatic excursion and encourage pursed lip breathing if they are conscious enough.
Next T.
Next T, you apply the appropriate oxygen delivery device, carefully titrating to the target's PO2. Then you utilize airway clearance techniques like huff, coughing, or chest physiotherapy to mobilize those purulent secretions.
I want to dig into oxygen as a medication for a second. We established that oxygen requires an order and must be titrated, not just cranked up. But earlier we talked about absorption atelectasis. Is that the only danger of high oxygen? Because instinctively my brain still says more oxygen equals better tissue perfusion.
And that instinct is what causes oxygen toxicity. Yeah, when you expose the delicate lung tissue to a high FiO2, specifically anything greater than 60% for more than 24 hours, you trigger a severe inflammatory cascade.
How does that work?
Oxygen, chemically, is highly reactive. At high concentrations, it overwhelms the body's antioxidant defenses and creates oxygen-free radicals.
Like reactive oxygen species that physically tear apart cellular walls.
Precisely. These free radicals directly damage the endothelial lining of the alveolar capillary membrane. They literally burn the lungs at a microscopic level.
Wow.
And when that membrane is damaged, it becomes highly permeable. Fluid and plasma proteins leak out of the capillaries and flood the alveoli. You create severe, non-cardiogenic pulmonary edema.
So by giving too much oxygen, you're physically building a moat of fluid inside the lung that oxygen molecules can no longer swim across. You create an impenetrable barrier to gas exchange.
Yes. You induce a massive right-to-left pulmonary shunt, meaning blood goes through the lungs and comes out the other side, just as deoxygenated as when it entered. That's why the priority action is always the lowest possible FiO2 to meet your target saturation.
That makes total sense. Let's look at a physical procedure to help with gas exchange without just relying on a wall flow meter. Pursed lip breathing. This seems so basic. Breathe in through the nose, blow out slowly through pursed lips. But the physics behind why this works is vital.
It is entirely about pressure dynamics. When a patient with emphysema or severe bronchitis breathes out forcefully, the pressure inside their chest rises.
Okay.
Because their airways are floppy and have lost elastic recoil, that rising intrathoracic pressure actually crushes their bronchioles from the outside in.
Oh, so the airway collapses before the air can escape.
Exactly. The air gets trapped in the alveoli.
So they're hyperinflated. They literally can't get the stale air out to make room for fresh air in.
Right. But when you use pursed lip breathing, prolonging the exhalation so it's 2 to 3 times as long as inhalation, and forcing the air through a narrow opening at the lips, you create back pressure.
Like a physical splint.
Exactly. That gentle positive pressure travels all the way down the respiratory tree and acts as a physical splint. It holds the floppy bronchioles open just long enough for the trapped air to escape.
It's natural PEEP, positive end expiratory pressure created by the patient's own mouth. That's brilliant. And for getting those thick secretions out, we can use positive expiratory pressure devices like the flutter valve, acapella, or Therapep.
Right. As they exhale against resistance, the device oscillates.
Which sends vibrations down the airway to shear the mucus off the bronchial wall so it can be coughed up.
Now, let's talk about the hardware we use to deliver oxygen. As an intensivist, you have to understand the difference between low-flow and high-flow systems. Low-flow devices, like a standard nasal cannula delivering 2 to 6 liters, or a simple face mask, do not meet the patient's total inspiratory demand.
Right, if I take a deep breath, I'm pulling in air much faster than 6 liters a minute.
Exactly. So the patient pulls in the oxygen from the cannula, but they also pull in a ton of ambient room air around it.
Right.
Because of this mixing, you never actually know the exact FiO2 you're delivering. A non-rebreather mask with a reservoir bag can deliver higher concentrations, roughly 60 to 90%, but it's still considered a low-flow device because it relies on the patient's breathing pattern.
But if we need precise mathematical control over the oxygen concentration, which we do if we're worried about oxygen toxicity, we have to move to high-flow devices.
The classic example is the Venturi Mask. It uses the Bernoulli principle.
Okay, remind me how that works.
It pushes pure oxygen through a narrowed orifice, which creates a pressure drop that physically drags in a precise adjustable amount of room air. Regardless of how fast or deep the patient breathes, the Venturi mask delivers a guaranteed exact FiO2, say exactly 40%.
And then there's the high-flow nasal cannula, which is just a total game changer. It can deliver precisely blended oxygen and compressed air, heated to 37 degrees Celsius and 100% humidified at massive flow rates up to 60 liters per minute.
Right. It washes out the dead space in the upper airway and provides a mild amount of positive pressure.
But RK is failing high-flow oxygen. His RR is 32, his SpO2 is 84%. He needs more than just oxygen. He needs mechanical support. Before we put a plastic tube down his throat, we have to consider non-invasive ventilation, or NIV.
Let's do some crucial pattern recognition here. CPAP versus BiPAP. I feel like these get thrown around interchangeably, but they are fundamentally different tools.
They are entirely different. CPAP stands for continuous positive airway pressure. It delivers one single constant pressure during both inspiration and expiration.
Think of it like sticking your head out the window of a moving car. The air is just constantly pushing in.
Which is fantastic for obstructive sleep apnea, right? It physically pneumatic stents the pharynx open so the airway doesn't collapse while they sleep. It restores functional residual capacity, or FR2.
Yes, but CPAP has a major drawback for a patient in acute respiratory distress. It significantly increases the work of breathing during exhalation.
Oh, because the patient has to forcefully push the air out of their lungs against that constant incoming hurricane of pressure.
Exactly. Which means if I have a heart failure patient whose heart is already exhausted, putting them on CPAP might actually tire out their respiratory muscles even faster.
So that's where BiPAP comes in, bi-level positive airway pressure.
BiPAP delivers two distinct pressures. It gives an IPAP, or inspiratory positive airway pressure, when the patient breathes in.
Right.
This is a higher pressure, say 15 centimeters of water, that gives a massive boost to the tidal volume, helping the patient blow off retained CO2 and reducing the work of breathing.
And then it drops down to an EPAP, or expiratory positive airway pressure, when they breathe out. This is a lower pressure, say 5 centimeters of water, which is just enough to keep the alveoli splinted open for oxygenation, but low enough that the patient doesn't have to fight to exhale.
Exactly. If you see a severe COPD exacerbation with retained CO2, or acute decompensated heart failure with pulmonary edema, your brain should immediately think BiPAP. The IPAP clears the CO2 and pushes the fluid out of the alveoli, and the EPAP keeps the sacs open.
But here is the critical deterioration warning. This is where bedside vigilance separates a good nurse from an elite one. The patient is getting worse What happens if RK's level of consciousness drops while we have this tight-fitting BiPAP mask strapped to his face?
That is an absolute drop-everything emergency. The cardinal rule of non-invasive ventilation is that the patient must be awake, alert, cooperative, and physically able to remove the mask themselves.
Because if RK becomes obtunded and his stomach is filling with air from the positive pressure which happens, he might vomit. And if he vomits into a mask that is strapped to his face while a machine is blowing air into his lungs under high pressure,
the machine will forcefully blow that vomit directly into his trachea and lungs. He will suffer a massive aspiration event which carries a staggering mortality rate. If a patient's LOC drops on BiPAP, they have lost the ability to protect their airway.
Which brings us to escalation. You notify the provider for minor adjustments. But if hemodynamics become unstable on NIV, if their heart rate skyrockets, or if we look at RK's blood pressure of 84/49 that warrants an immediate rapid response and preparation for endotracheal intubation, NIV is no longer safe.
Let's hit a quick ICU pearl that always shows up on exams. If you have a patient with severe COPD and marked hyperinflation, meaning their lungs are overdistended and their diaphragm is flattened out, you must never teach them diaphragmatic breathing during an acute exacerbation.
Wait, really? I thought diaphragmatic breathing was the gold standard for relaxation and lung expansion.
For healthy lungs, yes. But in severe COPD, the diaphragm is already pushed down and flattened by the trapped air. If you force them to try and push it down further during an acute attack, it drastically increases their work of breathing, worsens their dyspnea, and consumes massive amounts of oxygen.
Oh, wow.
You must stick to pursed lip breathing to stent the airways open instead.
Okay, let's tie this pre-intubation phase together using the intensivist thinking framework.
Right.
Problem: profound hypoxemia, failing physiology, alveolar obstruction from secretions and bronchial collapse, immediate threat, brain death and respiratory arrest. Intervention: titrated oxygen and considering non-invasive ventilation. Reassessment: continuously watching the LOC, SpO2, and ABGs.
To crystallize this, here are the absolute core takeaways for this phase, if you only remember 5 things. 1. The core pathophysiology blasting high oxygen washes out nitrogen, causing absorption atelectasis and alveolar collapse.
2. The key assessment finding a dropping level of consciousness in a patient on non-invasive ventilation means impending failure.
3. The most dangerous complication, oxygen toxicity, where free radicals physically burn the alveolar capillary membrane.
4. The priority action: always use the lowest FiO2 possible to maintain an SpO2 greater than 92%.
And 5. the most important treatment for air-trapping pursed lip breathing to create positive expiratory pressure and prevent bronchiolar collapse.
So your one-sentence clinical picture is this: a COPD patient with thick secretions, a rising respiratory rate, and dropping oxygen saturations despite a nasal cannula.
Right, and if you see decreasing LOC on BiPAP, think inability to protect the airway and do prepare the room for immediate endotracheal intubation.
Excellent. Now, before we secure RK's airway, we need to address a sudden complication. Let's say that right after the ED team put RK on BiPAP, the high positive pressure caused a weak bulla, a blister on the surface of a COPD-damaged lung, to rupture. Suddenly, air is rushing out of his lung tissue and into his chest cavity.
We have just entered pleural space emergencies.
We need to talk about reestablishing the negative pressure, because right now, RK's left lung sounds have completely vanished, and his blood pressure, which was already 84/49, is dropping even further. The 80-20 overview here is based on simple, vital physics.
Exactly. The pleural space is the microscopic gap between the visceral pleura lining the lung and the parietal pleura lining the chest wall. In a healthy human, this space is a vacuum. It possesses negative subatmospheric pressure.
And that vacuum is what keeps the lung sucked out against the chest wall. When your chest expands, the vacuum pulls the lung open with it.
But if that seal is broken, whether from a ruptured bleb, like in RK's case, a stab wound, or thoracic surgery, that negative pressure is lost.
So if atmospheric air rushes in, that's a pneumothorax. If fluid or blood accumulates, that's a hemothorax.
The physics dictate that the moment the pressure inside the chest becomes positive, it physically crushes the spongy lung tissue. The lung collapses.
The pathophysiology trigger is the loss of the seal. The physiologic change is the accumulation of positive intrathoracic pressure.
Right, and the body's immediate compensation is a rising heart rate and respiratory rate to try and maintain cardiac output and oxygenation.
But the decompensation is rapid. The positive pressure doesn't just crush the lung, it compresses the superior and inferior vena cava. Venous return to the heart plummets.
No blood returning to the heart means no blood pumping out of the heart, which explains why RK's blood pressure is tanking. The clinical findings are absent breath sounds on the affected side, profound hypoxemia, and worsening hypotension. We have to use a chest tube to evacuate that air and restore the vacuum.
When we place that chest tube and connect it to a drainage system, our assessment becomes highly specialized. You're assessing the patient's respiratory status, sure, but you must also assess the mechanics of the drainage system.
The most crucial finding in the water seal chamber is titling.
Let's explain titling because it's a brilliant indicator of internal physics. The water seal chamber acts as a one-way valve. It lets air out of the chest but prevents room air from going back in. When a spontaneously breathing patient inhales, they create more negative pressure in their chest. This physically pulls the water in the chamber up the tube. When they exhale, the pressure pushes the water back down.
That rhythmic up and down movement of the water level with each breath is titling. It tells you the system is patent and in direct communication with the pleural space. You also need to assess the insertion site on the patient's chest for subcutaneous emphysema.
That's when air leaks into the tissue under the skin. It feels like Rice Krispies or bubble wrap when you palpate it.
Yeah, exactly.
A tiny amount around the insertion site might be expected, but if that crackling sensation starts spreading up the patient's neck, it can physically compress the trachea and compromise the airway.
The dangerous findings you must look for in the system are a sudden, complete cessation of titling in a lung that hasn't healed yet, which indicates the tube is kinked, clotted, or occluded, or, conversely, continuous, rigorous bubbling in the water seal chamber.
Diagnostics are relatively straightforward here. A stat chest x-ray to confirm the tube is in the right place and to visualize how much the lung has re-expanded.
Let's run this through ADPIE. Our nursing diagnosis for this is decreased cardiac output related to positive intrathoracic pressure and impaired gas exchange.
And the planning goal.
The measurable planning goal is complete lung re-expansion with fluid drainage less than 100 milliliters per hour.
Implementation means meticulous system management. You must keep the drainage unit below the level of the patient's chest at all times. Gravity is your friend.
Right. If you lift the unit above the chest, all that drained fluid will flow right back into the pleural space.
You ensure all tubing connections are tightly taped with spiral taping to prevent accidental disconnections. Evaluation is simple. You know it worked when the titling gradually slows down and eventually stops.
Why does it stop naturally? Because as the air is evacuated, the lung re-expands. Eventually, the visceral pleura of the lung expands so fully that it presses right up against the eyelets of the chest tube, physically blocking them. The vacuum is restored.
Let's walk through the priority nursing actions for a chest tube patient. First, you always assess the patient. Listen to breath sounds, check their CO2, evaluate their work of breathing.
Next, you assess the system. Verify the water seal is intact and check the suction regulator.
Then, you trace the tubing from the patient to the box, ensuring it is unkinked, loosely coiled on the bed to prevent dependent loops, and positioned below the chest.
For the procedure itself, understand that tube size matters based on what you are draining. If you are draining thick, clotted blood from a hemothorax, you need a massive tube, 36 to 40 French.
Wow.
Yeah, if you're draining serious fluid, a 24 to 36 French works. If you're just evacuating air from a pneumothorax, air is thin, so a small 12 to 24 French tube placed higher in the chest is sufficient since air rises.
We also have two types of suction systems, wet versus dry. Wet suction uses a physical column of water to regulate the maximum amount of negative pressure pulled from the wall, usually set at 20 centimeters of water.
Right. If you turn the wall suction up too high, the water just boils harder, doesn't pull more vacuum on the lung.
And dry suction uses a mechanical regulator dial, which is quieter and doesn't evaporate.
Let's talk about massive complications. If you have a patient with a massive pleural effusion and the provider drains 1.5 liters of fluid out of the chest in 10 minutes, what happens?
The lung, which has been crushed for weeks, suddenly re-expands, but that rapid shift in pressure dynamics pulls massive amounts of fluid out of the pulmonary capillaries and into the alveoli.
Right.
It's called re-expansion pulmonary edema. The patient will suddenly develop severe dyspnea, frothy sputum, and profound symptomatic hypotension as fluid leaves the vascular space.
Exactly. The nursing action is prevention. You must ask the provider before the procedure exactly how much drainage is the maximum limit for one sitting. If you hit 1 to 1.5 liters quickly, you clamp the tube to let the hemodynamics equilibrate before draining more.
The most terrifying complication is the tension pneumothorax. The cause is usually a blocked drainage tube, maybe a huge blood clot, or a nurse inappropriately clamping the tube.
Right, so air continues to leak from the lung into the chest cavity, but it has no way to escape. The pressure builds exponentially.
The findings are catastrophic, sudden, severe respiratory distress. The trachea will physically deviate away from the affected side because the pressure is pushing the entire mediastinum over.
And the blood pressure will bottom out completely as the heart is crushed. The immediate nursing action is to unclamp the tube, ensure it's not kinked, and call for emergency help.
Let's focus on deterioration alarms for the nurse at the bedside. The patient is getting worse for drainage volume, if a post-op patient dumps more than 200 milliliters of blood in the first hour or consistently drains more than 100 milliliters per hour after that, they are hemorrhaging.
You notify the surgeon immediately.
And we touched on bubbling. Let's clarify the physics of the water seal bubbling. If you see intermittent bubbling that corresponds with the patient exhaling or coughing, that is perfectly normal for a pneumothorax. It just means the trapped air is being pushed out of the chest.
But if you see continuous, rigorous bubbling like a jacuzzi,
that means there is a persistent air leak. Air is entering the system constantly. The question is the leak coming from a massive hole in the patient's lung, or is there a crack in the plastic tubing? How does the nurse find the leak?
You methodically clamp down the tubing. First, ensure all external connections are tight. If it's still bubbling continuously, take a padded clamp and briefly clamp the chest tube right at the insertion site on the patient's chest.
Okay.
If the bubbling instantly stops, it means the source of the air is the patient. Maybe the tube is migrated out and the eyelets are exposed to room air.
But if you clamp at the chest and the water seal is still bubbling,
then the leak is in the system itself. Room air is getting sucked into a crack. You move the clamps down the tubing inch by inch toward the drainage unit. The moment the bubbling stops, you know you just clank below the leak. You've pinpointed the crack between your last two clamp points, and you simply replace the tubing.
Here is the ultimate escalation scenario. You walk into the room, and the chest tube has completely disconnected from the drainage system. It's lying on the floor. Room air is poised to suck right into the patient's chest. Instinct says to clamp the tube shut.
Do not clamp the tube.
Yeah.
If the patient has an active air leak from their lung, clamping the tube guarantees a lethal tension pneumothorax. The immediate life-saving intervention is to grab a bottle of sterile water or even tap water in a dire emergency and submerge the distal end of the chest tube 2 inches into the water.
You literally build an emergency water seal. The water allows the positive pressure from the chest to bubble out, but the physical weight of the water prevents room air from rushing back up the tube. That is a brilliant piece of physics to have in your back pocket.
And let's hit a massive ICU pearl and a classic exam trap here. Never ever milk or strip chest tubes to clear blood clots.
Stripping is when you pinch the tubing near the chest and slide your fingers all the way down to forcefully pull clots out. Why is that lethal?
Because of Boyle's law. By forcefully stripping that tubing, you're creating a massive transient negative pressure inside the closed system, sometimes pulling up to negative 400 centimeters of water pressure.
Oh my God.
Yeah, that violent suction is transmitted directly to the delicate healing lung tissue. You'll physically tear the lung, causing a massive new pneumothorax or severe hemorrhage. If there is a visible clot, you gently squeeze and release the tubing called milking, only if absolutely necessary and permitted by your hospital policy.
Okay, intensivist thinking for the pleural space. Problem: accumulation of pleural fluid or air, failing physiology. Positive intrathoracic pressure is compressing the lung parenchyma and the heart. Immediate threat: tension pneumothorax leading to cardiac arrest. Intervention: chest tube insertion and maintenance. Reassessment: monitoring titling, drainage output, and follow-up chest x-rays.
Let's summarize the 5 core things here. 1, the core pathophysiology: loss of negative pleural pressure collapses the lung and physically crushes the vena cava, decreasing venous return to the heart.
2, the key assessment: finding continuous, uninterrupted bubbling in the water-sealed chamber equals a system air leak.
3, the most dangerous complication of tension pneumothorax caused by unnecessarily clamping or occluding the tube.
4, the priority action: if the tube disconnects from the drainage unit, immerse the distal end in sterile water immediately to create a makeshift seal.
And 5, the most important treatment principle: keep the drainage system completely upright and below the level of the chest and never strip the tubes.
Your clinical picture: a post-thoracotomy patient who develops sudden, severe respiratory distress, tracheal deviation, and absent breath sounds on the operative side.
Right. And if you see a sudden stop in titling accompanied by respiratory distress, think tube occlusion or tension pneumothorax, and do assess the patient. Check the tubing for kinks, unclamp if clamped, and call for emergency help immediately.
Okay, our case chest tube is in. The pneumothorax is resolving, but his respiratory rate is still 35. He is completely exhausted, and his ABGs show he is retaining massive amounts of CO2. His brain is shutting down. We can't avoid it anymore. We are moving to phase 3, the ultimate takeover: mechanical ventilation.
This is the core of ICU nursing. The 80-20 overview here is that mechanical ventilation does not cure a single disease.
Right, it is entirely supportive.
It is a bridge that keeps the patient alive while antibiotics, steroids, or time heal the lungs. But to build this bridge, we have to use positive pressure ventilation, or PPV. And PPV completely reverses normal human physiology.
This is, without question, the most crucial intensivist concept we will discuss today: the hemodynamic shift. If you do not understand this physics, you will kill your patient when you intubate them. Let's walk through the pathophysiology step by step.
Right. Normally, human beings breathe using negative pressure. When you decide to take a breath, your diaphragm contracts and drops down. This expands your chest cavity, creating a vacuum-negative intrathoracic pressure.
Right. Nature abhors a vacuum, so air rushes in through your mouth to fill the space.
But that vacuum does something else, too. That negative pressure in your chest acts like a suction pump for your cardiovascular system. It literally pulls venous blood from your body up through the inferior vena cava and into the right atrium of your heart.
So normal physiologic breathing actually helps fill the heart with blood. It augments preload.
Precisely. Now look at what happens when we paralyze RK, put a tube in his trachea, and hook him up to a ventilator. The machine pushes air into his lungs under positive pressure. We are blowing up his lungs like balloons inside a closed box.
And that positive pressure doesn't just stay in the alveoli. It pushes outward against everything in the chest cavity.
Right. It pushes against the heart. It physically compresses the superior and inferior vena cava.
Yes. By switching from negative pressure to positive pressure, we are essentially stepping on the hose of venous return.
Exactly. Blood cannot easily flow back into the chest. According to the Frank Starling law of the heart can only pump out what it receives.
So decreased venous return means decreased right ventricular preload. Decreased preload means decreased cardiac output.
And a massive drop in cardiac output leads directly to profound, life-threatening hypotension.
Let's bring this back to RK. This is terrifying. He is sitting in the ED right now with a blood pressure of 84/49. He is already profoundly hypotensive. If we push a sedative, paralyze him, and bag him with positive pressure, we are going to crush whatever tiny amount of venous return he has left.
If you intubate him right now without preparation, his blood pressure will hit 0, and he will go into pulseless electrical activity cardiac arrest PEA within 60 seconds.
Wow.
This is why the intensivist mindset requires you to manage hemodynamics before you manage the airway. RK needs a massive fluid bolus and likely a peripheral vasopressor infusion like norepinephrine started immediately to artificially tank up his vascular volume so it can push past the positive pressure we're about to inflict on his chest.
That is a phenomenal breakdown. So the tube is in, he is stabilized on fluids and pressors. Our assessment of the ventilated patient is ongoing. We are looking at patient-ventilator synchrony. Are they resting comfortably or are they fighting the vent?
Right, are they biting the tube, coughing, or using accessory muscles?
And we heavily evaluate the ABCDEF bundle every single day.
The bundle is the cornerstone of preventing ICU-acquired weakness and delirium. It involves assessing readiness for awakening trials, stopping sedation, breathing trials, testing if they can breathe without the machine. Choice of analgesia and sedation, prioritizing pain control over deep comas, delirium prevention, early mobility, and family engagement.
Immediately post-intubation, we need diagnostics. We need an EtCO2 capnography monitor attached.
Capnography is gold. If you see a steadily rising carbon dioxide value and a square waveform on the monitor, it absolutely confirms the tube is in the trachea.
And if the waveform is flat?
The tube is in the esophagus, pushing air into the stomach, and you must pull it immediately.
We also need a stat chest x-ray to confirm the tip of the endotracheal tube is 2 to 3 centimeters above the carina, the point where the trachea splits into the left and right bronchi. And we draw ABGs 15 to 30 minutes after placing them on the vent to see how our settings are working.
Running this through ADPIE for the intubated patient. Assessment. Recognize respiratory failure, apnea, or severe muscle fatigue. Diagnosis. Impaired gas exchange and high risk for decreased cardiac output related to positive pressure.
Planning. Stabilize ABGs without causing hemodynamic collapse.
Implementation involves securing the airway with commercial devices, setting vent modes, and providing meticulous oral care with chlorhexidine to prevent infection.
An evaluation is seeing an improved PaO2 and PaCO2 while maintaining a stable mean arterial pressure greater than 65.
Let's detail the priority nursing actions. First, stabilize those hemodynamics with fluids or pressors and ensure oxygenation.
NEXT.
Ensure the tube is absolutely secure. You must physically mark the position of the tube at the lips or teeth, for example, noting that it is at 23 centimeters at the right lip, and document it.
Right, because if you come back an hour later and it's at 26 centimeters, the tube is slipped down, likely right main stem, intubating the patient.
Exactly. Then you initiate ventilator-associated pneumonia VAP prevention immediately. The head of the bed must be up 30 to 45 degrees, and you start strict oral care.
Let's dig deeply into the medications. To get the tube in, we use rapid sequence induction, or RSI. RSI is the concurrent administration of a potent sedative and a paralytic agent to induce unconsciousness and complete paralysis as rapidly as possible, minimizing the time the airway is unprotected to prevent aspiration.
For sedation, we might push propofol or etomidate. Propofol is highly lipophilic, crosses the blood-brain barrier instantly, and knocks them out in seconds.
But propofol is a massive vasodilator, right?
It is. Given RK's blood pressure of 84/49, propofol might completely crash his pressure. The provider might choose etomidate instead because it preserves hemodynamic stability much better.
Exactly. And concurrently, you push a paralytic, a neuromuscular blocking agent like rocuronium or succinylcholine. This stops all skeletal muscle movement, relaxing the jaw and vocal cords so the tube can pass smoothly.
But this leads to a critical non-negotiable rule regarding NMBAs once the patient is on a continuous paralytic drip in the ICU. Please listen carefully to this because it is horrifying if you get it wrong.
Okay.
Paralyzed patients can still hear, see, and feel everything. A paralytic drug does absolutely nothing for pain, and it does absolutely nothing for anxiety or consciousness. It only blocks the acetylcholine receptors at the neuromuscular junction so the muscles cannot twitch.
Meaning, if you don't sedate them, they are fully awake.
You must never, ever paralyze a patient without concurrent, continuous sedation and analgesia. Imagine being fully conscious, feeling a massive plastic tube shoved down your windpipe, hearing alarms blaring, and being entirely unable to open your eyes, move a finger, or even take a breath. It is literal torture.
To ensure they are adequately paralyzed but not overdosed to the point where it takes weeks to wear off, we use train of 4 or TOF testing. We use a peripheral nerve stimulator, usually on the ulnar nerve at the wrist, and deliver 4 electrical shocks. We count the thumb twitches.
The goal is usually 1 to 2 twitches out of 4. If they have 4 twitches, the paralytic dose is too low. If they have 0 twitches, they are profoundly overblocked, and you need to turn the drip down to prevent prolonged myopathy.
We also need medications for GI and VTE prophylaxis. Mechanical ventilation and the associated low cardiac output shunt blood away from the gut to save the brain and heart.
Right, and that ischemic gut is highly prone to stress ulcers. So we must give a proton pump inhibitor like esomeprazole or an H2 blocker like famotidine.
And because they are paralyzed in bed, we give enoxaparin to prevent deep vein thrombosis.
Now, let's unpack the vent settings. We need to understand the hemodynamics, respiratory, and ABG implications of what we program into the machine. Let's start with the most important setting, PEEP, positive end expiratory pressure.
Break down the physics of PEEP.
PEEP is a constant positive pressure applied by the ventilator at the very end of exhalation. Normally, a healthy human has about 5 centimeters of water pressure naturally, provided by the closure of the glottis, your vocal cords.
Okay.
This physiologic PEEP keeps your alveoli from snapping completely shut when you breathe out.
But when we put an endotracheal tube in, we physically wedge the vocal cords open. We've removed their natural PEEP.
Exactly. So we must dial in at least 5 centimeters of PEEP on the ventilator just to replace what we bypassed. If a patient has ARDS or severe pulmonary edema, we might crank that PEEP up to 10, 15, or even 20.
Why so high?
High PEEP is a brilliant tool because it forcefully splints open collapsed alveoli, recruiting massive amounts of surface area for oxygen to cross into the blood. It dramatically improves oxygenation without having to use toxic levels of FiO2.
But everything in the ICU is a trade-off. What is the physiological cost of high PEEP?
The cost is worsening the hemodynamic shift we discussed earlier. Higher PEEP means higher continuous pressure trapped in the chest cavity. The vena cava gets crushed even harder. Venous return drops further, and blood pressure tanks. Furthermore, if you pump too much PEEP into stiff lungs, the alveoli can stretch until they literally pop.
Which causes barotrauma pressure damage. A popped alveolus leaks air into the pleural space, causing a tension pneumothorax. That's why managing a vent is such a delicate dance between oxygenating the blood and keeping the heart pumping.
Let's briefly hit the modes of volume ventilation. The most common initial mode is assist control, or AC. This is full support. You program a set tidal volume, say 500 milliliters, and a set backup rate, say 12 breaths a minute.
If the patient is completely paralyzed, the machine breathes 12 times a minute, giving 500 milliliters every time. But what if the sedation wears off a bit and the patient tries to take a breath on their own?
The machine senses their effort and instantly steps in to deliver the full preset volume. The patient triggers it, but the machine does all the work.
But what's the danger there?
The danger is that if a patient wakes up in pain or anxiety and starts breathing 30 times a minute, the AC mode will enthusiastically force 500 milliliters of air into their lungs 30 times a minute.
Which means they will rapidly blow off massive amounts of CO2. Their blood will become extremely basic, leading to severe respiratory alkalosis.
Then there is SIMV, synchronized intermittent mandatory ventilation. This is often used as a partial support or weaning mode. The vent guarantees a set number of mandatory breaths at a set volume.
But in between those mandatory breaths, if the patient wants to take extra breaths, the machine lets them do it entirely on their own, pulling whatever tiny or large volume they're capable of. It forces their respiratory muscles to do some work, preventing atrophy.
And finally, PSV, pressure support ventilation. There is no set rate and no set volume. The patient must be awake and initiating every single breath.
So when they breathe in, the machine just gives a gentle boost of positive pressure to help them overcome the physical resistance of breathing through a narrow plastic tube. It's essentially the vent version of BiPAP.
What about fluids and electrolytes on the vent? I've noticed that patients who have been on mechanical ventilation for 48 to 72 hours almost always start puffing up with massive fluid retention. They become edematous. Why is the vent causing them to hold water?
It's a fascinating chain reaction. It all traces back to cardiac output. As we know, positive pressure decreases cardiac output. When the cardiac output drops, less blood flows to the kidneys.
Right.
The kidneys are incredibly sensitive to perfusion drops. They panic. They assume the body is bleeding to death.
So the kidneys activate the renin-angiotensin-aldosterone system, or RAAS. Aldosterone forces the kidneys to aggressively reabsorb sodium, and water follows sodium.
Concurrently, the intense physical stress of critical illness causes the pituitary gland to release massive amounts of antidiuretic hormone, ADH, and cortisol. The body clamps down and hoards every drop of fluid it can.
That's why we have to meticulously track intake and output and frequently rely on diuretics like furosemide once the patient is hemodynamically stable to offload that fluid before it backs up into the lungs.
Let's run through complications: the cause, the finding, and the nursing action. The most insidious is VAP, or ventilator-associated pneumonia. By definition, this occurs more than 48 hours after intubation.
The cause is almost always microaspiration. Even with the endotracheal tube cuff inflated, tiny amounts of bacteria-laden saliva pool above the cuff and slowly trickle down into the sterile lungs.
The findings are a new fever, a spike in white blood cells, purulent sputum, and worsening oxygenation.
And the nursing action is strict adherence to the VAP bundle. Keep the head of the bed elevated 30 to 45 degrees to use gravity against aspiration, perform meticulous oral care with chlorhexidine to kill the bacteria, and do daily sedation vacations to assess if we can pull the tube out.
Another major issue is auto-PEEP. We set the PEEP on the machine, but sometimes the patient develops their own dangerous level of PEEP. How does that happen?
Auto-PEEP is caused by inadequate exhalation time. If the patient is breathing very fast, or if they have COPD and their airways are floppy, they start the next breath before they have fully exhaled the previous one.
The air gets trapped.
Breath by breath, the pressure stacks up inside the lungs. It causes massive hyperinflation and sudden hemodynamic instability because the vena cava gets crushed.
The immediate action is to disconnect the vent for a few seconds to let them fully exhale, then adjust the vent settings to increase their expiratory time.
Well, let's talk about the constant beeping, deterioration alarms. The patient is getting worse if you cannot just stare at a beeping screen. You need to know what the machine is telling you. Let's divide them. High-pressure alarms versus low-pressure alarms.
If a high-pressure alarm goes off, think resistance. The machine is trying to push the preset volume of air in, but it is hitting a physical wall. It requires too much pressure to deliver the breath.
So what builds a wall in the airway? It could be the patient biting down on the plastic tube. It could be a massive mucus plug completely blocking the bronchus, meaning they need immediate suctioning.
Right.
It could be severe bronchospasm where the airways clamp shut, or, most dangerously, a tension pneumothorax where the lung is compressed and cannot accept air.
Conversely, if a low-pressure alarm goes off, think leak. The air is escaping too easily. There is zero resistance. That means a physical disconnection in the corrugated tubing, the balloon cuff on the ET tube has deflated or ruptured, or the most terrifying option, an unplanned extubation.
Which brings us to escalation. You walk into the room, and RK, who you thought was sedated, is sitting up, holding his endotracheal tube in his hand. He has extubated himself. What is the immediate life-saving response?
You stay with the patient, you immediately yell for help or hit the staff assist button, you do not leave the room, you grab the bag valve mask connected to the flow meter on the wall, turn it to 15 liters of 100% oxygen, and manually ventilate the patient while you wait for the team to arrive to re-intubate.
Let's look at differentials in pattern recognition. What if you have a patient, maybe it's RK on day 4, who has severe life-threatening hypoxemia despite being on 100% FiO2 and incredibly high PEEP? The lungs are failing completely, and the vent is no longer enough.
If you see refractory hypoxemia despite maximum vent settings, think ARDS, acute respiratory distress syndrome. The lungs are completely flooded with inflammatory fluid, and the alveoli are like concrete. You must prepare for rescue therapies.
This is where we break out the big guns. Proning, flipping the paralyzed patient onto their stomach.
I admit this always confused me. If their lungs are failing, why on earth would putting them face down magically make them oxygenate better? Aren't we just squishing their chest into the mattress?
It's all about VQ matching, ventilation, and perfusion matching. In a supine patient, gravity pulls all the fluid and edema into the dorsal posterior regions of the lungs.
Okay.
The back of the lungs gets completely flooded and crushed by the weight of the heart, but ironically, that's where most of the blood flow goes due to gravity. So you have blood going to crushed alveoli.
Which creates a massive shunt.
Exactly. When you prone the patient, you physically flip them over. Gravity now pulls that fluid forward to the anterior lungs. This frees up the massive surface area-rich dorsal alveoli in the back.
Because blood flow is still relatively high in those posterior regions, you suddenly match open, functioning alveoli with high blood flow. Oxygenation drastically improves.
We might also use inhaled pulmonary vasodilators like nitric oxide or epoprostenol. These are gases pumped directly into the vent circuit. They dilate the pulmonary capillaries only in the open alveoli, drawing blood exactly to where the oxygen is.
And ultimately, if all else fails, ECMO, extracorporeal membrane oxygenation, where we bypass the lungs entirely, pump the blood out of the body, oxygenate it in a machine, and pump it back in.
Let's hit some ICU pearls and exam traps for the vent. First is the deadly trap of alarm fatigue. In an ICU, you hear 1,000 alarms a shift. Your brain starts tuning them out. You must never silence an alarm without investigating the patient first.
Treat the patient, not the monitor. Look at their chest, look at their color, look at their hemodynamics before you hit the silence button.
And regarding suctioning the ET tube, we prefer closed suction systems because they maintain the PEEP seal and prevent environmental bacteria from entering the airway. You must hit the 100% O2 button to hyperoxygenate the patient before and after you suction.
But here is the major anatomical trap. Do not insert the suction catheter until you meet resistance.
This is a classic novice mistake. The instinct is to push the catheter deep to get all the mucus. But if you hit resistance, you've just slammed a hard plastic tube into the carina, the highly vascular nerve-dense bifurcation where the trachea splits into the lungs.
Aside from tearing the mucosal tissue and causing bleeding, what happens physiologically when you stab the carina?
The carina is loaded with vagus nerve receptors. When you stimulate the vagus nerve with a suction catheter, you trigger a massive parasympathetic reflex. The patient's heart rate will instantly plummet.
Oh, wow.
Yeah, you can induce severe bradycardia, heart block, or even sudden asystole just by suctioning too deep. You measure the catheter, insert it just past the end of the tube, apply continual suction while withdrawing, and limit your total pass to less than 10 seconds to avoid sucking all the oxygen out of their lungs.
Intensivist thinking for the vent problem. Apnea or acute respiratory failure. Failing physiology. Severe hypoxia and hypercapnia due to failing gas exchange. Immediate threat. Cardiac arrest from hypoxia or from the hemodynamic shift. Intervention. Intubation, positive pressure ventilation, and RSI. Reassessment. Constant monitoring of hemodynamics, capnography, and ABGs.
Let's lock in the 5 core takeaways from mechanical ventilation. 1. The core pathophysiology positive pressure ventilation drastically increases intrathoracic pressure, which crushes the vena cava, drops venous return, and tanks cardiac output.
2. The key assessment, a sudden high-pressure alarm combined with a dropping blood pressure strongly indicates a tension pneumothorax.
3. The most dangerous complication, unplanned extubation or ventilator-associated pneumonia.
4. The priority action, always hyperoxygenate before suctioning, limit passes to less than 10 seconds, and never push the catheter until it hits the carina.
And 5. The most important treatment principle, execute the ABCBEF bundle and daily spontaneous breathing trials to get them off the vent as quickly as humanly possible.
Your clinical picture. A patient on assist control ventilation whose blood pressure immediately tanks from 120/80 down to 70/40 the exact minute the provider increases the PEEP from 5 to 15 centimeters of water.
Right. And if you see a chemically paralyzed patient with a rapidly rising heart rate, rising blood pressure, and tearing eyes, think inadequate sedation and analgesia while awake and paralyzed, and do immediately assess and titrate your sedative and opioid infusions up.
That brings us to our final phase, phase 4. Artificial airways and the path to freedom. Tracheostomy and weaning. Let's fast forward. Our case survived the intubation. He survived the hemodynamic crash. He battled through a bout of VAP. It is now day 12 of mechanical ventilation.
The 80-20 overview here is that endotracheal tubes are purely for short-term use. Yes, they bypass the upper airway and secure a route for air, but they carry massive compounding risks over time.
Right.
They act as a superhighway for bacteria, they cause severe ulceration of the vocal cords, and they require heavy sedation because they're incredibly uncomfortable. If an intensivist foresees that mechanical ventilation will be needed for more than 10 to 14 days, the standard of care is to switch to a tracheostomy.
A tracheostomy is a surgical hole, a stoma, placed directly into the trachea through the neck. It is far more comfortable, easier to clean, allows the patient to potentially speak and eat, and severely reduces the work of breathing because it cuts out all the dead space of the upper airway.
It facilitates weaning, but the ultimate goal of the ICU is always liberation, getting them off the vent, weaning the oxygen, and decannulation, removing the trach entirely.
The pathophysiology in this phase heavily revolves around the tracheostomy cuff. Much like the ET tube, most trach tubes have a balloon cuff at the end. When inflated, this cuff creates an airtight seal against the tracheal wall.
Right. This seal forces all the air from the ventilator into the lungs and prevents upper airway secretions from falling into the lower airway. But we have to strictly, obsessively monitor that cuff pressure using a manometer.
And this is where the cellular physics come into play. The tracheal mucosa is delicate tissue fed by microscopic capillary beds. The normal capillary perfusion pressure, the pressure required to push blood through those tiny vessels to keep the tissue alive, is roughly 25 to 30 millimeters of mercury.
So if the nurse inflates the cuff with too much air, and the cuff pressure exceeds 20 to 30 centimeters of water, which is roughly 15 to 22 millimeters of mercury.
The physical pressure of the balloon exceeds the pressure of the blood trying to enter the capillaries. The blood flow is completely blocked. This causes severe ischemia.
And, if left unchecked, the tracheal tissue undergoes necrosis, it dies and rots away. This leads to tracheomalacia, a floppy trachea, or a catastrophic tracheoesophageal fistula, which is a literal hole rotting through the back of the trachea directly into the esophagus.
Which means every time the patient eats, food goes straight into the lungs. That is preventable nursing negligence. So we monitor the pressure constantly. Now, for our assessment, we are constantly evaluating RK's readiness to wean off the vent. And it's crucial to understand that weaning isn't just about the lungs. Non-respiratory factors are huge.
You cannot wean a patient who is fighting a war on another front. Are they hemodynamically stable, or do they still require pressors? Is their hemoglobin greater than 7, meaning they actually have the carrying capacity to deliver oxygen to their tissues?
Are they a febrile?
Has the underlying cause of their respiratory failure, the COPD exacerbation, the pneumonia reversed? You cannot expect a patient to breathe on their own if they're in active septic shock.
For diagnostics, we look at objective weaning indices. These are math equations that predict if a patient has the mechanical strength to survive off the vent. The big one is the Rapid Shallow Breathing Index, or RSBI. We want an RSBI of less than 105. Let's break the math down so it makes physiological sense.
RSBI is calculated by taking the patient's respiratory rate and dividing it by their tidal volume in liters. If a patient is breathing very fast, say 35 breaths a minute, but taking tiny weak breaths, say 0.2 liters, their RSBI would be 175.
And 175 is way above the threshold of 105. But why does rapid shallow breathing predict failure?
Because it indicates profound diaphragmatic fatigue. When respiratory muscles are exhausted, they can't pull deep volumes, so the body compensates by breathing faster to maintain minute ventilation. But rapid, shallow breaths only move air back and forth in the dead space of the trachea. They don't reach the alveoli. If their RSBI is over 105, they are failing.
We also measure negative inspiratory force, or NIF. We temporarily occlude the airway and measure how hard the patient can suck air in. We want a NIF that is more negative than negative 20 centimeters of water. If they can pull negative 30 or negative 40, it proves their diaphragm is strong enough to take a deep breath and clear a cough. And we look for a spontaneous tidal volume greater than 5 milliliters per kilogram of body weight.
Let's structure the ADPIE for the weaning phase. Assessment. Perform a daily spontaneous awakening trial, SAT, coupled with a spontaneous breathing trial, SBT.
Planning. Transition the ventilator to a supportive mode like pressure support, PSV, or CPAP, where the patient does the work.
Implementation is a coordinated dance. First, you perform the SAT. You turn off the propofol or sedation drips. You wait to see if they wake up calmly, without agitation or hemodynamic compromise.
If they pass the SAT, you immediately roll into the SBT. You drop the vent support and let them breathe for 30 to 120 minutes.
Evaluation. They are ready for extubation or weaning if they maintain stable vital signs, perfect ABGs, and minimal work of breathing throughout the entire trial.
Let's hit the priority nursing actions for a newly placed tracheostomy. These are heavily tested and clinically critical. First, you must always keep a replacement tracheostomy tube of equal or smaller size, along with an obturator, visibly taped to the wall or at the bedside. If the track pops out, you have seconds to replace it.
Second, do not change the tracheostomy securing tapes for at least 24 hours post-insertion. The surgical tract is incredibly fresh and slippery. If you untie it, the patient might cough and shoot the tube across the room.
And then, when you do change them after 24 hours, always use a two-person technique. One nurse physically holds the plastic flange flush against the patient's neck with their hand, while the second nurse changes the dirty ties.
For procedures, to prevent that tracheal necrosis we discussed, we use the minimal occlusion volume technique to inflate the cuff. You don't just pump it full of air. You place a stethoscope on the patient's neck over the trachea. While they are on the vent, you slowly inject air into the cuff, just until you no longer hear an air leak during peak inspiration.
You use the absolute minimum volume of air required to seal the airway, and then you verify the pressure with a manometer.
Let's talk about the psychological win of the ICU, the passing mirror valve. After weeks of silence, RK might finally be able to talk.
How exactly does this tiny piece of plastic let a patient with a hole in their neck produce speech?
It's a beautifully simple one-way speaking valve. it pops onto the outer hub of the tract tube. When RK breathes in, a little silicone flap inside the valve opens, allowing fresh air from the room to travel through the tract tube and down into his lungs. But when he tries to exhale, the pressure of his breath snaps the flap completely shut.
So the air can't go back out the plastic tube.
Exactly. Because the air can't escape through the tube, it is forced to flow upward around the outside of the tract tube, up through the vocal cords, into the mouth and nose. As the air passes over the vocal cords, it vibrates them, producing speech.
But there is a massive life or death safety point here that every nurse must memorize.
Yes. You must, without exception, completely deflate the tracheostomy balloon cuff before you place a speaking valve on a patient.
Because if the cuff is fully inflated, it creates an airtight seal against the tracheal wall. If you put a one-way valve on top of that, the patient breathes air in through the valve. But when they try to exhale, the valve closes. The air tries to go up through the vocal cords, but the inflated balloon blocks it.
The air is completely trapped in the lungs. With every breath, they stack more air. They cannot exhale. Within minutes, they will literally suffocate, develop a massive tension pneumothorax, and go into respiratory arrest. The mantra is, cuff down, valve on.
Let's discuss complications. The most frightening is accidental decannulation. The tract pops out of the neck. If the stoma tract is mature, meaning it's been surgically healing for months, it generally stays open like a pierced ear. You can calmly reinsert a new tube, but what if it's immature, less than 1 week old?
The tissue has not formed a tract yet. If the tube falls out, the layers of fat, muscle, and tissue will instantly shift, collapse, and close the hole completely. You lose the airway immediately.
Which is why deterioration monitoring during a weaning trial is so strict. The patient is getting worse if, during an SBT, they become tachypneic, breathing over 35, their heart rate spikes 20 beats above baseline, their CO2 drops below 92%, or they become agitated, diaphoretic, and use accessory muscles.
If you see those signs, you do not push them. You do not cheerlead them to tough it out. You immediately stop the trial, put them back on full AC ventilator support, and let their respiratory muscles rest for a full 12 to 24 hours before trying again. Muscle fatigue will completely derail the liberation process.
But let's go back to that immature decannulation. Escalation. The fresh tract pops out. You grab the spare tube and the obturator, but you cannot easily slide it back into the neck. You meet resistance. What is the immediate intervention?
Do not force it. If you force it, you will likely create a false tract into the mediastinum tissue rather than the trachea. If you cannot reinsert it easily, you immediately cover the stoma hole on the neck with a sterile, occlusive dressing to seal it.
Then what?
Then you grab the bag valve mask, place it over the patient's nose and mouth, and manually ventilate them from above just like a normal intubation code while someone calls anesthesia.
But there is a huge caveat here. What if the patient has a total laryngectomy?
That changes everything. In a total laryngectomy, usually for throat cancer, the surgeon completely severs the trachea from the upper airway and sews it directly to the skin of the neck. Their mouth and nose are no longer physically connected to their lungs.
So if you put a mask over their mouth and squeeze the bag,
You are just pumping air into their stomach. You will never oxygenate a laryngectomy patient from the face. For those patients, you must apply the pediatric bag valve mask directly over the stoma on their neck and ventilate them through the hole.
let's look at a differential pattern recognition that is guaranteed to show up on exams and in practice. Knowing the difference between fenestrated versus non-fenestrated inner cannulas.
Tract tubes have an outer cannula that stays in the neck and a removable inner cannula that you pull out to clean. A fenestrated inner cannula has a physical hole, a window cut into the dorsal surface. This hole allows even more air to pass upward over the vocal cords to help with speech when the cuff is deflated. A non-fenestrated tube is completely solid plastic.
And the ICU exam trap is this. You must ensure a non-fenestrated inner cannula is in place when you are suctioning the patient.
Exactly. If you try to pass a suction catheter down a fenestrated tube, the tip of the catheter can easily slide out through that little hole. Instead of going straight down the trachea, the rigid plastic tip shoots out the side and directly tears into the mucosal tissue of the trachea, causing severe hemorrhage. Always use a solid inner cannula for suctioning.
That is an excellent pearl. Another quick ICU pearl. Swallowing is significantly impaired when a tract cuff is inflated. The inflated balloon anchors the larynx, preventing the normal upward and forward movement required to swallow safely. Because of this, long-term tract patients absolutely require a formal speech-language pathologist evaluation for aspiration risk before they are ever allowed to take a sip of water by mouth.
Let's lock in the intensivist thinking for this final phase. Problem, prolonged ventilator dependence, failing physiology, respiratory muscle atrophy, and exponentially high risk for VAP.
Immediate threat, failure to wean resulting in permanent mechanical dependence or lethal infection.
Intervention, meticulous daily SAT-SPT protocols, and surgical tracheostomy. Reassessment, constantly checking RSBI, NEEF, and hemodynamic parameters during trials.
And the 5 core things for tracheostomies and weaning. 1. The core pathophysiology, high cuff pressure greater than 30 centimeters of water, physically blocks capillary blood flow, causing tracheal ischemia and tissue necrosis.
2. The key assessment in RSBI of less than 105 and a NIF more negative than -20 indicate the diaphragm is strong enough to begin weaning.
3. The most dangerous complication, accidental decannulation of a fresh, immature tract leading to complete airway loss.
4. The priority action always, without exception, completely deflate the tract cuff before capping the tube or applying a Passimier speaking valve to prevent suffocation.
And 5. The most important treatment principle, meticulous, daily, interdisciplinary coordination of spontaneous awakening and spontaneous breathing trials.
Your one-sentence clinical picture. A recovering ARDS patient on day 12 of mechanical ventilation who is continually failing daily SBTs due to muscle fatigue and is scheduled for a percutaneous tracheostomy to facilitate weaning.
And if you see accidental dislodgement of 2-day-old tracheostomy, think immature tract closure, and do immediately cover the stoma, manually ventilate via the mouth and nose unless they are a laryngectomy patient, and call a code immediately.
Let's step back and synthesize this massive journey we just took. We started in the ED with the microscopic physics of nitrogen washout, absorption atelectasis, and pursed lip breathing. We restored the physical vacuum of the pleural space.
Then we moved into the life-or-death hemodynamic shift of positive pressure ventilation, understanding exactly how fixing a patient's lungs can inadvertently crush their vena cava and crash their heart.
We covered the pharmacology of RSI, the intricacies of vent modes, and the terrifying reality of tension pneumothoraxes and unplanned extubations.
But despite all the glowing screens, the peak inspiratory pressures, the waveforms, the complex vent modes, and the math equations, it all comes back to the human element. It comes back to RK, sitting in that bed.
Yeah.
The entire goal of everything we discussed today is liberation. Getting that plastic tube out of his throat, minimizing his sedation so his brain can recover without delirium, getting his family involved at the bedside, and aggressively using early mobilization to keep his body from wasting away into ICU-acquired weakness.
That is the essence of critical care. The ventilator is a brilliant machine, but it is just a bridge over troubled water.
I want you to think about the absolute irony of the ICU for a second. To save a life, we inflict immense trauma. We put patients into medically induced comas. We chemically paralyze their skeletal muscles so they cannot move. We cut holes in their necks. We use powerful machines to forcefully blow air into their delicate lungs with positive pressure that literally fights their own heart's ability to fill with blood. We do all of this calculated violence to the human body entirely to give it a fighting chance to heal. The ventilator doesn't cure a single disease. It just buys you time.
That is exactly right. You are buying time for the antibiotics to work, or the heart to rest, or the inflammation to subside.
So the real provocative question for you, the elite ICU nurse standing at the bedside, silencing the alarms and watching that monitor, is this. How are you using that borrowed time? What are you doing in the muddy waters of that diagnostic landscape to ensure that your patient actually wakes up, takes a deep breath of room air on their own, and walks out the doors?